I would like to introduce myself. I'm Engelke, former professor of the University of Göttingen, meanwhile retired. And I would like to present you something about the topic of app log, which probably is something new for most of you. I have been professor in the city of Göttingen, the University of Göttingen. This is an old picture of Göttingen in 300 years ago. This is the center of our university in the center of the city, and this is not Göttingen, but it's University Hospital in Bremen, where I was for some years as an assistant doctor in ENT. I proceeded from Bremen to Hanover in Germany. Hanover may be a city which is quite known. And there I worked in phoniatrics and also cleft lip and palate for some years in the 80s. Afterwards, I changed to the University of Göttingen again. And this has been my life until now, until 2018. So 3 years ago, I retired from the University of Göttingen. But let's have a look what has been happening in Göttingen. Göttingen has a number of about 40 persons who won a Nobel Prize or who worked for a time of their life in scientifically in Göttingen. So the history of Nobel Prize in Göttingen is quite common. I worked for about 30 years on the mobility, on the activity, and on the anatomy of the velum palatinum. So I did a postdoctoral degree, a PhD degree in 1991, mainly with the method of electromagnetic articulography. That's the device which has been shown here with a colleague of mine some years later. But the center of my investigation always has been and is still the velum palatinum. And you may have a look at this, where the velum palatinum is measured with the electromagnetic sensor, which we fixed at the velum, also at the tongues. So we could register the movement path of the velum, and we could observe the movement of the velum during speech and deglutition. Later on, I was director of the orofacial dysfunction clinic in the University of Göttingen, and I was in charge of patients with different disorders of the orofacial system in general. I also conducted some clinics in the context of implantology and regeneration of the maxillary and mandibular bone reconstruction with a lot of different methods. So those types of clinical activity and as well as scientific activity I carried out for many years. A look at PubMed will show you that I also published some articles in the past. You may look at this later on. The publications concerning the topic of today, the uplog breathing, were published first in 26, when I reported on a maneuver which led to a tongue repositioning, which I talked at that time. The tongue repositioning maneuver nowadays is called the uplog maneuver. I proceeded with this topic in another publication in 2010, which was directed to the clinical use of this maneuver for the treatment of snoring, and which has been published in the European Journal of Orthodontics. And later on, we presented a biofunctional model. The biofunctional model I'm going to present you today, which covers the anatomical and the functional aspects of the system of nose, mouth, and throat. So nose, mouth, and throat is the field of work which I did for all my life, not ENT, but nose, mouth, and pharynx. Some years ago, I published a work with when using the magnetic resonance tomography in order to define the position of different parts of the system, different parts of the tongue, of the velum, and other structures during swallowing. During suction and swallowing, we can observe interesting change of position of the articulators and the structures which are part of the orofacial system. And so we could give a survey about the displacement of these structures during swallowing. From 2010, I cooperated with the University de la Frontera in Chile, and one of my doctoral students now is professor at that university. At present, I'm not associated to an organization, but I'm working in some hospitals and clinics near Göttingen as a freelancer surgeon and physician. Very important in my life. Last year, I met Dr. Khan, and Dr. Khan contacted me by email asking for a cooperation in the scientific field. And I really appreciate that Dr. Khan has been very engaged in the, not only in the promotion, but in the development of the technique of uplock breathing, of uplock maneuvers, which we are going to present today. And really, Dr. Khan made it possible that a new era of this research could be started last year. With Dr. Khan, I made already 2 courses this year in the town of near Göttingen. This town is called Witzenhausen, near the Weser River, and it's quite a nice little medieval town where I also propose that you visit us maybe next year in Germany. So we founded the Uplock Academy, and the name Uplock Academy will be explained just in a few minutes in detail. But let's have a look first on the most important topic, breathing. Breathing through the upper airway may be a breathing through the mouth or through the nose. And this is the question, mouth or nose. In sports, we observe usually a complete oral breathing through the mouth. It's obvious that sports people are acquainted to mouth breathing, and that the nasal breathing is some very unusual for sports people. But we know that for growth, for rest, and for regeneration, the nasal breathing is very important. So nasal breathing supports the correct development of the dental arches and the tooth position, and is obviously necessary in orthodontics and in dentistry and in other fields. So the question, how the structures of nose, mouth, and throat are placed relatively to the airway. This is a very important question, which has been addressed by different disciplines in a quite complex manner. This is a drawing for school children to get an idea of these three organs. This draft was taken from a textbook of phoniatrics, showing the mouth breathing. This chart comes from Garliner, David Garliner, who started myofunctional therapy. This is a draft from the internet showing everything and the general anatomy. Here you can see the anatomy of the 50th with open mouth and the position of a dead body which always shows a downward position of the tongue. Another representation of the system, the graphic representation, but here you can see a quite ugly drawing of a German dental maxillofacial surgeon. He showed some special posterior closure of the mouth. It's the only one of 9 different charts who explained a posterior closure of the mouth. Here you can see the view of the dentist when treating snorers, and this one was taken from a publication, American publication, Dr. Profit, who published this. So you may have an idea that the vision of this system of nose, mouth, and throat is quite uniform, concerning that mouth and nose is represented quite well, but the rest of it is nearly undefined, and it is impossible to find a common idea what is the function of the posterior part of the oral cavity, what is the function of the throat during rest, for example. Just a look at myofunctional therapy. Here we can see that myofunctional therapy as is presented by the MyoBrace concept requires nasal breathing, what is very important, and recommends the positioning of the tip of the tongue at the papilla incisiva. But also in this concept, we do not have any idea what's happening inside the throat and what is happening between the tongue and the velum palatinum. So this is the difficult area here, posterior to the tongue, posterior to the tongue, posterior to the tongue. Nobody knows what's happening here and if it is of relevance for the complete function of the orofacial system or not. I think that the Uplock breathing concept changes something concerning the problem of the role of the velum palatinum and the role of some new aspects which are not identical with the tip of the tongue, but which show us a new concept of valving mechanism. So look at this conductor of the orchestra. This is an active woman who is conducting this orchestra. But imagine if the director needs some rest. He cannot maintain his hand in this position for half an hour, for 1 hour, for 2 hours, just to rest. It is impossible. The hand will fall down, and he needs something to support the hand in order to get to rest. So we have the 2 principles of solid mechanics during start and landing and fluid mechanics during the flight. This can be demonstrated when the plane is landing. For example, here, the fluid mechanics is active. At this point, there is switch point from fluid mechanics to solid mechanics, and on the ground, the solid mechanics are being used. The other way around, first solid mechanics on the runway, then at the point of takeoff, the switch point to fluid mechanics, and during the flight, fluid mechanics. And something similar also can be observed in the mouth. But to explain this, I would like to explain first the biofunctional model, which has been explained more in detail in our publication with Michael Knösel in 2015 in German and in 2018 in English. So let's have a short look to the biofunctional separation of nose, of throat, and mouth. We observe functional units which can be defined as functional unit 1 and 2, the lips, functional unit of the basis of the maxilla and the mandible, and functional units of the superior teeth and the inferior teeth. These functional units can be separated and observed and judged separately. Then the tongue is a unique functional element which can be subdivided in an anterior and inferior posterior part, 7A and 7B. Another important point is the velum palatinum, which is the functional unit number 8, and which, as you could see in the majority of publication, is not represented sufficiently. So biofunctional unit number 8 is the velum palatinum. It's my favorite organ, and I worked with it more than 30 years. So the number 9 is the pharyngeal constrictor, which acts during swallowing, and which is very important to cooperate with the number 8 unit, especially when the bolus passage is directed into the esophagus. As functional units in the context of nose, mouth, and pharynx, it's only the entrance of importance, not the complete airway. So entrance to the larynx is number 10, and the entrance to the esophagus number 11. And the final and 12th unit is the number 12, being used to lead the breathing air through the nose and maybe subdivided, but this is not the topic of today. I would like to remind you on the German surgeon. Do you know who it is? It is Sauerbruch, Ferdinand Sauerbruch. Ferdinand Sauerbruch also talked about fluid mechanics, and Ferdinand Sauerbruch was the first surgeon who did surgery of the thorax, and he formed a special compartment for the patient and the surgeon, and a compartment which allowed the patient to breathe while the thorax was opened. In the moment of the reduction of the pressure inside this compartment, the patient was able to breathe, and the surgeon was able to work in this compartment. So the formation of compartments is of utmost importance in the surgery of the thorax, and in many parts of the medicine. So Sauerbruch used this principle for many years, but we know that another technique, the intubation, also is able to achieve the same effect, but the formation of the compartments is different, although the principle is the same. So the formation of compartments has been known in medicine since the days of Sauerbruch, and this is the principle which can be observed also in the system of nose, mouth, and throat. I would like to show you the concept of the biofunctional model based on the valving mechanism. We can define a total of 7 valves. Now, the first valve is the valve of the lips. It is shown here, the valve number 1, obviously a valve which can close and which is resistant against fluids. The second valve is quite difficult to explain. I will later show you some photos which may explain it in detail, but we know that the second valve is also very important. It is formed between the hard palate and the tongue, and it's a U-shaped valve, which includes the lateral parts of the tongue, the anterior parts of the tongue, and the corresponding parts of the hard palate. The valve number 3 is formed between the velum palatinum and the tongue. So in between these 2 valves may be formed a compartment, a special compartment, which we are going to show later on. The velum palatinum has another function. It may act as closure of the 4th valve, the valve number 4, which closes the nose against the pharynx and which is used by speech. If you do not use it, your speech is changing dramatically. I show you how. You may have an idea what happens if the velum palatinum does not work. Number 5 valve is the larynx. The entrance of the larynx is also quite complicated. The glottis and the epiglottis together form this valve, and it also is being subdivided into at least 2 different valves which can be work synchronously. Number 6 is the entrance to the esophagus, and this valve is quite simple. It opens only if the bolus passage is introduced, and mainly it is closed. The last valve, number 7, is the entrance to the nose, and this valve can be closed only partially. The majority of time it is open, but it can be closed by pressing the nose. Based on these valves, on the 7 valves, we are able to define a number of 4 and not of 3 different compartments. This is very important because in the mouth, we up to now thought about only one compartment, the oral cavity. But this oral cavity can be subdivided into the so-called Frankel space, a space all around the upper and lower dentition, which is formed when the valve number 2 and valve number 1 and valve number 2 are closed. So this space is formed, the Frankel space. Between the second valve and the third valve, another space is formed if these valves are closed, and this second space is called the Donder space. The space usually is closed before swallowing, and if there is a connection between this space and the external air, then a swallowing act may be impeded. It is important to close this space completely before swallowing. The third compartment is the compartment of the pharynx, which also can be subdivided, but will be closed towards the nose when the velum palatinum closes here. So at that point, there is uncertainty of the position of the third compartment, depending on the position of the velum palatinum. Into this direction, the valves 5 and 6 close the third compartment. And then there is a compartment number 4, which is represented by the nose and the epipharynx together. Epipharynx and nasal space together form the compartment number 4. I think explaining the compartments gives us a new perspective to the function of the system of nose, mouth, and throat, especially the function of the mouth area, and the opening and closure of the valves allows to give a new idea of what can happen during breathing when the mouth is closed. This does not mean that only the lips are closed, but quite different mouth closure may result from this concept. So please keep in mind that there are two different modes of working. We have the fluid mechanic and the solid body mechanics. The solid mechanics, the fluid mechanics. Both types of physical action may be present in the system of mouth, nose, and pharynx. So this is the new of our concept of the uplock concept of breathing, that both of the mechanical, the fluid mechanical and solid mechanical can influence the complete system. I would like to go just a few minutes into history to explain that this concept of mechanics has been described already some 150 years ago. In 1873, Mr. Tomes, Dr. Tomes, already talked about the influence of muscle activity on the growth of mandible and maxilla and on the position of the teeth. This is pure mechanics, and not fluid mechanics, but solid body mechanics. So this is quite common, and we can state we would expect it. But at the same time, also in 1875, so I just switch to the next. Here we are. Also in 1875, Mr. Donder made experiments with the pressure formation inside the mouth. And Donder could measure negative pressures in the space between the hard palate and the tongue. Therefore, we gave this space the name Donder space. This is the Donder space, which has been examined and described in 1875. Going further in history, we look at the work of Edward Engel, and Engel mainly referred to muscle action. So Engel did not take the concept of fluid mechanics, but the concept of solid mechanics and muscle action. As many others, the great majority of investigators in the last century talked about muscular action, muscular influence, and muscular fractures, which may have any effect on the growing dentition. As Edward Engel also did, you will find this in a large number of publications, and I'm not able to show it all, but I only want to stress that based on the idea of the solid mechanics, the majority of orthodontists took their ideas and built up their treatment concepts. In Germany, there was a different opinion in ENT. In 1953, the Dr. Eckhard Möbius published about the suction chamber of the mouth, which are identical with what we define now within the biofunctional model. This suction chamber, which was named according to Eckhard Möbius with the letter S, with this suction chamber was based on the observations of Donde, and later on was taken by Dr. Franke. Dr. Franke, also an Eastern German orthodontist, made a very interesting exercise. He put his students a plastic between the lips and the dental jaw. Between the lips and the upper and lower dental arches, and then he asked them to swallow. So swallowing had the effect that the students of Dr. Franke could not open their mouth again. You may just do the same exercise at home using a plastic and swallow, then it's very difficult to open the mouth. And this is not difficult because of muscle tension, but by forming a negative pressure compartment. I repeat it, the formation of a negative pressure compartment enables a person to spontaneously open the mouth. This is the experiment of Dr. Franke. Let's go to another group of investigators, the group of Engelke in 1991 observed also negative pressure in the Donde space. They did not depict the function of the velum palatinum, but they observed negative pressure in this area, although positive pressure in a variety of other locations inside the mouth. They observed it, but they did not take any consequences. So just some years later, our work group reported on the same aspect, and we find it to be important to put all this together into a functional model, because without a functional model, it is nearly impossible to have an idea of the importance and an idea upon the potential clinical use of this factor of fluid mechanics. Fluid mechanics in the Frankel space and fluid mechanics in the Donde space are of importance for a variety of therapeutic measurements, of therapeutic exercises, and of the treatment of respiration disorders, which we are going to address later on. This biofunctional model, based on 12 functional units, gives us a comprehensive view on the position of valves inside mouth, nose, and throat. And based on these valves, we can explain a large variety of functions in a new way. It is not only muscle action, it is also the formation of compartments. So these 4 compartments with 2 different compartments in the mouth, and a compartment in the pharynx, other compartment in the nasopharyngeal area, which extends to the complete nose. These different compartments have different tasks and may be described quite exactly in order to describe and to analyze speech, to analyze swallowing, to analyze breathing, and to analyze activity of chewing. Looking at this model in 3 colors, it gives us an interesting idea of what is the actual state of the art. You know that the muscle action, which is here in green, that the muscle action mainly is thought of the muscle action is based on the activity of the tongue and of the lips and the perioral muscles. This is myofunctional concept, myofunctional therapy. And between these two muscles, groups of muscles, the dental arches, as well as the basis of the mandible and the maxilla, find their position during growth and after treatment. But the yellow areas and the yellow aspects of the formation of enclosure of compartments and the yellow area of the pharynx, the yellow area of the velum palatinum, the constrictor pharyngeal, and the pharyngeal, the pharyngeal constrictor, and the laryngeal complex. The yellow areas in the majority of investigations are not represented adequately. This is very important to know. The most important action of muscles is supported or inhibited by the function, the formation of these compartments and the action of the velum palatinum and the constrictor. So we have to look at the function of the constrictor, of the velum palatinum, and of the larynx during swallowing, especially in order to understand what is happening. One important point is that we observe a change from fluid mechanics to mechanics of solid bodies. Solid bodies are not always solid, but they are different from fluids. So in the body, the solid body mechanics are used when muscles act against hard tissue structures, but completely different is the principle of fluid mechanics, which may stabilize this space, the Donder space, or which may stabilize the Frankel space. So please keep in mind fluid mechanics and mechanics of hard tissues, mechanics of solid bodies. These two different things define the function of our system. We explained the valves which divide the compartments. Right. The 7 valves, in general, divide a total of 4 compartments. The 4 compartments I defined in the 2 compartments in the mouth area are divided by valve number 2 and 3. And this compartment is being closed during swallowing. I would like to switch over to the swallowing process in order to clarify this. Valve number 1, valve number 2, number 3, number 4, this is the velum palatinum. Number 5, the entrance to the larynx. Number 6, and number 7. Okay, this is quite clear, but the importance is what happens with the valves during swallowing. In real time, it's nearly impossible to clarify the process of swallowing if there is no clear concept which explains step by step the action. Looking at it another time, it doesn't change the problem of understanding it. So what happens during swallowing? At the first time, the Donder space between valve 2 and 3 is filled with the pineapple juice. The second stage, the displacement posteriorly, just without opening of the valve number 3. And now closure of the valve number 4 by the contraction of the pharyngeal constrictor together with the maintenance of the bolus inside the Donder space. And now the next movement is very, very fast. So the bolus in this position is accelerated and rapidly expelled by action of the velum. So the velum is pulled rapidly in this direction, and by opening the valve number 3, the bolus proceeds rapidly into the esophagus. So this is only just some milliseconds, some 20, 30 milliseconds, which are being used to propel the bolus here. And finally, and this is important, finally, the system is being stabilized. Stabilization implies that the valve 1, 2, and 3 keep being stabilized. They keep being in a contact position after the passage, the rapid passage of the bolus, and the airway is open. And this is the uplock position. The uplock position means that the compartments around the teeth, the franchial compartment, the compartment below the hard palate, and obviously the valves are closed. And by closing these valves, the tongue maintains a position in contact with the palate without need of further muscle action. The muscle action initiates the swallowing, but after the swallowing, the function of the tongue is not continuously pressure against the hard palate, but only the formation of a closed compartment. And there is a shift of different mechanical and of different physical principles from the mechanics of hard tissue to the mechanics of fluids. Just like in the airplane, you can observe it also in the plane. Here we have a look at the function based on the model. On the left side, the chart from the magnetic resonance tomography. On the right side, the model. Breathing through mouth and nose before this uplock mechanism, then closure of all these valves 1, 2, 3, and 4, including the closure of the pharynx, the complete pharynx, and finally opening with the closure of the valve 1, 2, and 3, with opening of the valve number 4. So this mechanism is uniform. It can be observed always using magnetic resonance tomography, where the flow of the bolus and the opening of the airway can be demonstrated quite clearly. We made an animation in order to show the action of the structures. As you can see, at first, closure of the lips, the bolus in this position. If it is only saliva, then there will be a very small bolus, and the tongue is in contact with the palate. The number 3 valve is closed, still breathing through the number 4 valve. Now, the expansion of the velum palatinum in the posterior superior direction, just with the saliva inside the Dunbar space, and now the rapid opening of the number 3 valve with the transport of the saliva in direction of the esophagus. And after this passage of the saliva, then the reopening of the airway. This reopening of the airway is a very important aspect which could be observed already in the 90s using electromagnetic articulography, and which has been confirmed now by the real-time MRI. So this reopening is a mechanism that by swallowing, and formation of compartments with negative pressure, the airway opens immediately after the use of this swallowing activity to reposition the tongue and the velum palatinum. And this is the use of our device, placement of the vacuum activator, and muscle action to give more tension to this activator as Frenkel did. And now the action of swallowing. And during swallowing, the formation of the negative pressure in the Donder space will take place. So now the closure of the number 4 valve is still present, and the opening of the 4th valve then is observed, and the position of the tongue depends on the position of on the presence of negative pressure here in this space. It is easy to do this exercise at home. Here you can see the device which is being used. This funnel and the membrane show the negative pressure which can be observed in the Frenkel space. It's quite easy to observe the negative pressure, and the formation of negative pressure is an indicator that the compartments 1 and the compartments 2 are closed. You also may use a manometer in order to measure the pressure inside the mouth during this exercise. Here, the vacuum activator. The same can be measured with the Bluetooth device, which transmits the pressure values on the screen of the smartphone. So every exercise may be taped and may be transmitted to the therapeutic person. This is the vacuum activator and the instructions for use. And in the past, we combined the measurement of pressure with pulse oximetry. Pulse oximetry allows to observe if during the uplock stage, that means during the complete closure of the mouth over a time of between 5 and 10 minutes, a decrease of the saturation occurs, and if there is any risk for the patient who uses the device concerning the cardiovascular problems. We also may measure the Donder space and the Frenkel space in parallel. So you may use the same system with 2 indicators, which can be used without any electronics, just observing the inversion of this membrane. And the membrane indicates if the negative pressure is formed and if the compartments are closed. In case of swallowing disorders, one of the channels may be used to inject any fluid into the mouth to teach the use of fluid for formation of the negative pressure and to improve the swallowing function. This is important to know that the measurement can be done here in the space between the tongue and the hard palate, which we call Donder space. The measurement also can be done here in the Frenkel space. Another time, measurement of the oxygen saturation, and at the same time, the measurement of the negative pressure formed inside the compartments. As you can see here, 12 millibar is the mean value which we intend to achieve. The 12 millibar mean value does not have any traumatizing effect to the gingiva. Every excess of negative pressure may have side effects, so it is important to control that the patient uses the unit in an adequate manner and that he learns to maintain the pressure in the area between 10, 15, 20, at least 10 to 15 millibars. There's another chart showing the generation of negative pressure. Here you can see that the negative pressure is not high enough and has to be corrected in a later session. During swallowing, however, the patient produces high negative pressure in the peaks. So the swallowing action, the swallowing function may be judged also with the same device and based on the formation of negative pressure peaks. But have care that the negative pressure, which is continuously used during rest, does not exceed the value of 15 millibars. Today we're talking about snoring and obstructive sleep apnea, especially about the mandibular advancement device and the uplock training, the uplock maneuver. First of all, I would like to reference Dr. Friedrich von Esmarch. Friedrich von Esmarch was the inventor of a maneuver which leads to a mandibular advancement and also to mouth opening in order to rescue lives in unconscious patients. So the Esmarch maneuver has been used for decades and has saved millions of lives of the patients who suffered from apnea during injuries and during other types of diseases. So the Esmarch maneuver also has been introduced in dentistry. In Germany, the Deutsche Gesellschaft für when the AHI is below 25, that means not only snoring, but also for situations with obstructive sleep apnea, but not with an AHI over 25. The second condition is that the BMI is below 30, so obese patients have to be excluded. Another condition is if the AHI is over 25 in case of non-acceptance of the CPAP device, and also if the CPAP treatment shows non-compliance. A lot of devices has been used in the past. A number of about 24 of protrusive devices which have been used in this study. The survey of Hofstein in 27 is still actual and reports about 49 studies which have been analyzed concerning the use of protrusive devices and the general success rate. The AHI showed a basic value of 35, and after treatment with the advancement device, the AHI was 14 in the complete study. That means that there is a sufficiently good effect of the advancement devices in general, but on the other hand, the Esmarch treatment, which is generally a treatment of acute apneas, may have some severe side effects when used with chronically used splints. The use of protrusive splints may lead to excessive salivation as well as to a dry mouth. We can observe sometimes jaw discomfort and also TMJ pain, TMJ discomfort, muscle discomfort, until to muscle pain, and sometimes the occlusal changes can be observed during the treatment. Therefore, in dentistry, the treatment with the SMAC device must be directed to maintain an occlusal concept clearly defined. It has to regard the TMJ load and has to avoid an overload of the temporomandibular joint. The vertical jaw relation may be altered and must be addressed. Muscular dysfunction is quite frequent, and the hyper and hyposalivation may be a problem for the patient. In the treatment of patients with snoring and with obstructive sleep apnea, endoscopy plays a major role. In the University of Göttingen, we performed an endoscopic evaluation of the epipharynx and of the upper airway before treatment with a protrusive device, an endoscopic evaluation of the epipharynx and the complete airway. So we can observe during free lock respiration, normal opening of the airway, looking at the same situation with uplock and with protrusion, using uplock respiration and protrusion, we can observe an enlargement of the airway with the inside just to the larynx. So the effect of the uplock respiration and the protrusive effect of the splint can be defined before the splint is inserted by the patient and before treatment is indicated. By endoscopic evaluation, we are able to judge the effect of uplock respiration and of protrusion just before integrating the protrusive splint. Here we can see the result of a study which was conducted on 50 patients before surgery when receiving a sedation before the general anesthesia. On the left side, we can see the endoscopic insight into the pharyngeal area, which was performed with a flexible endoscope through the nose into direction of the mesopharynx. And by this observation, we were able to observe the patency of the airway during protrusion, during uplock maneuver, and during the combination of both. The protrusion of patients after sedation during sleep was simulated by the maneuver of SMAC. The uplock maneuver was simulated by the use of an intraoral suction device, and here the combination of both also was observed endoscopically with both methods in function. The combination of protrusion and uplock maneuver was observed during the application of suction and the SMAC maneuver manually. Here are the main results of the study. We can observe in the spontaneous position without any maneuver, a baseline of the patency was defined by the number of pixels. So we observed during the initial situation spontaneously a degree of patency which is represented by this column compared with the column during the protrusion, during the uplock maneuver only, and the uplock maneuver and protrusion in combination. The results show clearly that the combination of the uplock maneuver together with the protrusion has the best effect. This could be shown statistically significant. So we can define that the uplock maneuver only and the protrusive position of the mandible according to the ESMA concept are two different methods which may work together in order to optimize the patency of the pharyngeal airway. I repeat the concept which is behind this treatment: the solid mechanics and fluid mechanics. Solid mechanics work to enlarge the airway by the protrusion of the mandible. Fluid mechanics are the factors which influence the position of the tongue in contact with the palate and which then lead to an enlargement of the airway by the maintenance of the tongue position on a fluid mechanical basis. Regarding the CPAP treatment, comparing the mask with the CPAP respiration and the situation when an uplock maneuver is carried out, it is clearly visible that the uplock maneuver stabilizes the tongue and the velum, which without the maneuver cannot be presented here in this chart. There is a gap between the tongue and the palate, indicating that this tongue position is not stable. However, the tongue position with the uplock maneuver is stabilized based on fluid mechanics. Concerning the use of different advancement devices, it is important to know which device can be in combination with the uplock maneuver and which device cannot be used. This very common device, the Thornton adjustable positioner, unfortunately does not allow the closure of the second valve and therefore cannot be used in combination with the uplock maneuver. However, the HELPS device may be used because the tongue here can contact the hard palate without being impeded to form a second seal between tongue and hard palate. And these devices, which can be based on upper and lower jaw splints, which are guided by intermaxillary strips, usually can be used in conjunction with the uplock maneuver. I want to repeat the concept of the combination of uplock maneuver and the protrusion according to the S-March concept. This is the uplock maneuver in the classical way. The closed valves number 1, number 2, and number 3. Here we can see the effect of the S-March maneuver when protruding it based on a spheric surface of the splints. This is one possibility to allow a variation of sagittal and lateral positioning of the mandible relative to the maxilla. The effect of the S-Mark device then can be improved and enhanced by posterior closure of the Donder space and negative pressure inside the Donder space. So the combination of protrusion and of the uplock maneuver can be applied in a correct manner. I again want to stress the influence of the solid mechanics on both jaws and the temporomandibular joint and the effect of the fluid mechanics on the position of the tongue when closing the valves, when closing the Donder space, and when attaching the velum palatinum and the tongue. In the transverse dimension, the uplock maneuver can be shown as follows. This is the free lock position, and this is the uplock position, which is based on fluid mechanical principles. So the uplock protrusive splint, the UPS, can be constructed using a edge-to-edge protrusive registration. Based on this registration, a spherical splint for the upper jaw and a corresponding splint for the mandible are performed. The bimaxillary splint allows a proper vertical adjustment of upper and lower jaw and lateral and sagittal movement, which can be performed freely without overload of the temporomandibular joint or aspects of the upper and lower occlusion. The adjustment of the sagittal position of the UPS is performed with intermaxillary elastic splint. The UPS and the vacuum activator are used together. The UPS allows a protrusion which is secured by intermaxillary elastics, and the vacuum activator is used to achieve a proper position of the tongue. This is shown again here, protrusion and closure of the compartments 1 and 2, opening of compartment 4 and 3 to allow proper breathing. The concept is different during the day and overnight. Exercises are carried out with the vacuum activator and the occlusion in central position. So this is the situation during the day when the vacuum activator is used. And overnight, the UPS is positioned with the protrusion of the mandible, and the negative intraoral pressure for compartment closure is achieved with the lip lock device. So this is the concept we think is quite new, a concept for maintenance of an adequate airway patency, and based on two principles: on the solid body mechanics, which is represented by the protrusive splint, and the fluid mechanics, which is based on the uplock maneuver. Thank you for your kind attendance, and I hope to see you soon in one of our courses. Thanks again.